This presentation is going to look at an exercise program for COPD patients and was produced by myself, Shane Spellman, and group members Julie Lucy, Nigel Hosford and Gillian Diestel. So the first thing that I'm going to address is the definition of COPD. What is it? Well, COPD, or chronic obstructive pulmonary disease, is defined by the American Thoracic Society as a condition characterized by airflow obstruction that reduces the ability to sufficiently empty the lungs. The term COPD includes two main conditions. We have emphysema. This is where the alveoli walls become damaged. This can be seen on the right-hand side. And chronic bronchitis, where the airways are irritated or inflamed. This can also be seen on the right-hand side image. The majority of people who have chronic obstructive pulmonary disorder have both emphysema and chronic bronchitis, and therefore the term COPD is more accurate. Next, I'm going to look into the prevalence of COPD. So there are over 600 million people with COPD worldwide, and in 2005 over 3 million people died because of COPD, and this accounted for 5% of all death globally. In 2012, it was the fourth leading cause of death in the world, and unless urgent action is taken to reduce risk factors, COPD will become the third leading cause of death worldwide by 2030. With regard to causes and risk factors, there are many causes of COPD, which include cigarette smoking, this being the most common cause. We've got secondhand smoke, air pollution, harsh chemical dust or gases, and of course genetics. Symptoms include breathlessness, constant cough, coughing up mucus, wheezing, chest tightness, fatigue, and exacerbations. So how is COPD diagnosed? It's diagnosed by a special breathing test or lung function test called spirometry. With this test, lung function is measured by calculating the total amount of air a person can exhale in 1 second. Results are then compared to healthy scores to determine a diagnosis or stage. A healthy individual should be able to breathe out about 80% of the air in the lungs in 1 second. Based on their score, they will either be considered a healthy individual or have mild, moderate, severe, or very severe COPD. So how is COPD treated? Although COPD is a chronic and progressive disease, it can be treated. The first step in controlling the COPD is to quit smoking and get vaccinations such as those for influenza and pneumonia, and this will greatly reduce acute exacerbation rates. Many patients also benefit from pulmonary rehabilitation programs, and these include exercise training, advice on healthy eating, and COPD education. Our exercise program is going to be broken up into an aerobic component and a resistance component. Aerobic training involving major muscle groups is advised for COPD sufferers, and we've taken this into account when designing our aerobic training program. We suggest walking training, and this has been backed up by the bulk of the available literature. However, if this is not feasible for a COPD patient, cycle and arm ergometry are also other proven forms of benefit. However, greatest increases in the 6-minute walk test have been seen from walking interventions, unsurprisingly. We've chosen resistance exercises to increase the strength and endurance of major muscle groups, and we've also included balance exercises due to our demographic we're working with. The average age is between 65 and 75 for most studies, and this is the rationale for this. Dressendorfer et al. 2007 recommended 2 to 4 sets of 6 to 12 reps at 50 to 85% of the 1RM, and we have adhered to this. Slowly progressing session frequency is more sustainable and something that we feel will lead to a greater lifestyle change, and at the end of the day, this is the objective for these types of interventions. Next, I'm going to be looking into who we're actually going to be working with. As far as inclusion criteria, the individuals need to have a confirmed diagnosis of COPD, they need to be receiving optimal treatment, the patient needs to be clinically stable, they need to be keen and motivated to attend the program, and have some means of transport to get to the venue. As far as exclusion criteria goes, pretty much any condition that someone has that would be aggravated by exercise or impair participation in the program. Obviously, we don't want to make anybody worse, therefore, if there's an underlying condition that puts them at risk, they would automatically be excluded. As far as benefits go, we've got improved functional exercise capacity, improved health-related quality of life, reduced breathlessness on exertion, reduced number of hospital admissions, reduced number of GP consultations, and reduced health service utilization. As you can see, the benefits are vast and can truly improve one's quality of life. Now on to our outcome measures. We've got the 6-minute walk test, and Brown et al. Has shown that 6-minute walk test has become the most widely used field exercise test in COPD. It's got formal guidelines for conduct, minimally clinically important difference of 25 to 35 meters, and it's got normal reference values. The table on the top left-hand side of the slide shows that someone would be given a very severe degree of impairment if they walked less than 152.4 meters in the 6 minutes. It also shows that they would be given a normal degree of impairment if they walked greater than or equal to 609.6 meters in the 6 minutes. We've also got the St. George's Respiratory Questionnaire. This is a widely used quality of life questionnaire in COPD, and it's also self-administered. It's been deemed valid and reliable for COPD patients, and the minimally clinically important response to treatment is defined as an improvement of only 4%. We've also got the modified Borg scale. It gives quick, easy, and rapid information about a patient's subjective state of dyspnea, this being difficult or labour breathing. It's a valid and reliable assessment tool for dyspnea, and correlated well with other clinical parameters and could be useful when assessing and monitoring outcomes. Patients who used the MBS rated it with a high degree of satisfaction on ease of use and found that the language in this scale adequately expressed their dyspnea. The table on the bottom right-hand side of the slide shows that it rates from 0 to 10, 0 being no breathlessness at all, 5 being severe breathlessness, and 10 being maximal. The table on the left-hand side of the slide shows our resistance program for the 12 weeks. It can be seen that our program is broken up into 3 blocks of 4 weeks each. Before any training begins, we have the pre-test, and this is the 1RM testing. We're doing this so that in week 1 then, we can tell the subject to do 2 sets of 8 reps at 50% of the 1RM, the score they'd got before we started any training. As I said, each block is broken up into 4 weeks, and the frequency of the sessions per week increases as we go. The first 2 weeks, it's 1 session per week. The next 4 weeks, it's 2 sessions per week, and the remaining 6 weeks is 3 sessions per week. It can also be seen in the intensity column that this increases as we go also. The reps and sets stay the same, however the intensity of 1RM gets greater. Each session will take 20 minutes to do, and even though the intensity is increasing, this won't affect the time. The type is going to be exercises 1 to 8 in the box on the right hand side. These will be discussed now. We've got the box squat. This is to improve leg strength. We've got the bench press to improve upper body strength, specifically in the pecs. We've got shoulder press. This again is just improving upper body strength. We've got the bridge to improve glute strength. This is considered one of the core muscles. We've also got the plank. This is to improve core strength. We've got the bicep curl and tricep extension, again just improving upper body strength. And we've got a balance complex. This is where an individual will stand on one leg for 10 seconds, then close the eyes for 10 seconds, stand on one leg for 10 seconds, and close the eyes for 10 seconds. This will be repeated on the other leg, and then they'll be finished their exercises for the day. The table shows our aerobic program for the 12 weeks. It can be seen, again, similar to the resistance training program. It's broken up into 3 blocks of 4 weeks each. Before any training begins, we have the pre-test. This is the 6-minute walk test, and it can be seen that the intensity for this will be around or 9 or 10, as it's a maximal test. The first 4 weeks, the frequency per week ranges between 1 and 2 sessions. The second block, between 2 and 3 sessions, and for the third block of 4 weeks, it's going to be 3 sessions per week. We see that the intensity increases as we go also. The first 4 weeks, it's going to be a 4 on the Borg scale. For the second 4 weeks, it's going to be 5 or 6 for the first 2 weeks, and then 7 for the remaining 2 weeks, and for the last 4 weeks of the whole program, it's going to range from a 7 to a 9. With regard to the time, the first 4 weeks is going to be a 15-minute session. The second 4 weeks is going to be a 20-minute session, and the third 4 weeks is going to be a 30-minute session broken up into 2 bouts of 15 minutes. It can be seen that our aerobic training is going to be walking, as this supports the bulk of the available literature. With regard to education, they're going to learn breathing control, the use and timing of medication, and when to stop exercising. For example, if they got to a 10 very early on in their session, they may have to stop. Barnett 2010 stated that increasing individual patients' knowledge and understanding of their condition and promoting self-management skills is crucial to enabling the patient to manage their condition more effectively, and we couldn't agree more. The next thing I'm going to look at is patient monitoring and patient safety. With regard to oxygen requirements, many patients may require ambulatory oxygen. Be sure the patient has the appropriate amount and can manage the weight of the tank when moving. This is Morgan et al. 2000. Oxygen saturation must be monitored during exercise using a pulse oximeter to ensure that it stays above a healthy 90%. With regard to cardiovascular conditions, unstable heart conditions can be too risky for the patients to exercise with, such as uncontrolled hypertension or a recent myocardial infarction. With regard to comorbidity, many patients have other diseases as well as COPD that may impair function, such as obesity, CV disease, cancer, etc. Special instructions by physicians and other professionals may be required to follow. With regard to COPD severity, while research shows that a light exercise program after an acute exacerbation of symptoms can be helpful, uncontrolled COPD is very dangerous, and thus oxygen levels and perceived exertion must be checked constantly. Finally, with regard to mental health, motivation may be lost often during rehabilitation, and depression or anxiety is common in patients. Frequent surveys about mood are important in keeping motivation as well as preventing any other further mental health issues. The final thing that I'm going to look into is issues of compliance. I'm going to look into causes of compliance and then ways to overcome the issues. Cause of non-compliance. The goal of pulmonary rehab is to manage symptoms and improve a patient's functionality because there is no direct cure. Because COPD is so debilitating, many patients have issues with depression, lack of motivation, and other psychological problems. Here's a way to overcome it. Provide realistic goals for the patient to achieve, as well as putting them in charge of their own progression. If they genuinely want to get better, it's possible through adherence to the program. Cause of non-compliance. Inconvenience and inability to travel to a rehab centre. Ways to overcome it. Provide community-based programs as well as home exercise programs. Cause of non-compliance. Sense of doubt over whether the program will work. Ways to overcome it. Education sessions in addition to exercise. Include disease info, management, and best care. Cause of non-compliance. Fear of breathlessness and lack of ability due to previously sedentary life. This is one of the main ones. Ways to overcome it. Education will help, but more important is having supportive, dedicated staff in the program who ensure the safety and improvement. Cause of non-compliance. Lack of continuation of exercise after the program ends. Again, a big one. Ways to overcome this issue. Instruct patients to keep a log of their exercise and improvements. Group environments and detailed instructions will also encourage more adherence. Thanks for listening.